presentation, and I think it is a very important presentation right now, because what I'm going to talk is in the current scenario is,
Can you share your screen, Dr. Abhishek?
is this available now?
Yeah.
So the issue with my presentation is that most of us are so adaptive, and there is very little literature available on the net or from others' experiences how to go about in this COVID era. India is fortunate enough to be one of the last countries to be hit by this corona pandemic, and I think we have learned a lot from others' experiences. So this is a photograph I think you all must have received. This is a funny picture, is that this is one of the last photographs which was taken in 2019. So what we can learn from this is that there would be some things which will change for forever, and there will be some things will be a temporary change, and we have to adapt ourselves. My first risk with operating in a lockdown on a major procedure was around 3 weeks back. It was a fresh macula on regumatogenous retinal detachment. I had no access to PP at that point of time. My institute did have. So I took and modified myself, adapted myself to operate under an HIV kit. There was no test for corona available, neither serological nor RT-PCR. The sole reliance was on a negative travel history, negative temperature charting, and other histories. And consent for COVID exposure to the patient was verbally explained, and no written consent was taken at that point of time. So this was my patient. What I have modified in this patient is that you can see this is a Muslim patient, and at that point there was a whole holla about the Jamaati thing that was happening at that point of time. And then we have we have asked the patient to wear an N95 mask for the patient, and from my own experience, the patients are very comfortable wearing an N95 mask. Only thing is that you have to explain it in the pre-op room, and you have to explain them that this is not going to be uncomfortable. This was around a 45-minute surgery, and the patient was very comfortable. What are the adaptations that I did myself was that I used a double mask. One was the N95 mask. I used a double gloves. I used a shoe cover. But I also learned from doing this, my first surgery in this COVID era, is that HIV kit is not a substitute for PPE kit. High quality masks and respirators are required at your disposal. You are very near to a patient who is already breathing. Look for fogging on spectacles or protective glasses before you don your PPE. That was my mistake in my second case, because once the fogging starts, this is not the time when you can just slip your mask off and the fogging will go off. So you have to be very particular about that the fogging is not there. Any procedure that involves greater than 5 minutes of interaction has a high risk of exposure from multiple sources, including patient and attendant. And general anesthesia can dramatically increase the risk. My second patient was a general anesthesia person. I had to take my PPE off, and there were almost 8 persons in the OT at that point of time. So it can get. What are the other things that I modified myself? I kept my personals to the minimal in this operation theater. Right? Normally in my operation theater, there would be an OT attendant who would be sitting there. There would be a separate person. This is my trainee fellow, Dr. Srishti, who is attending me. Not my fellow doesn't assist in my surgery. Generally, there is a separate assistant who assists me. So I asked him to wait outside. Then you must have a clear surgical approach, avoiding unnecessary steps. Like I avoided doing band buckling in this case to minimize the amount of time. In cases of procedure like phacoimmersive fusion, you can even avoid an assistant and try to complete the case by yourself. So this is how you should go about it. What are the adaptations done by us RIO in COVID era till date? We have been taking up emergencies, mainly emergencies, both GA and LA. We are not going to the elective cases till now. All patients planned for surgery after trials and history admitted in a separate isolation ward. So this is one adaptation that we have done. We admit all the patients in a separate isolation ward. Once the patient gets admitted in an isolation ward, they will undergo a mandatory COVID RT-PCR test. And this report usually takes 1 to 2 days to come, depending on the samples backlog. We are planning to introduce the serology also. So the patient will undergo 2 tests. One is the RT-PCR and another is serology. So once there is a patient who has been on the test comes. So there are two options that the patient can go. One is the patient will come negative. Once the patient comes negative, the patient is shifted to an RIO ward and is taken up for surgery after taking normal precautions. Once the patient comes for a positive, then we go for a contact tracing. We discharge the patient and shift the patient to a COVID dedicated hospital. IGMS is a non-COVID hospital. But then there is a big unanswered question. What about COVID positive with ocular emergency? We still don't have an answer to it. But then this is a thing that we have to go. What are the adaptations we have done in the further adaptations? Once shifted in the RI ward, we treat the patient as a false negative. That is a very important thing. Although the RT-PCR says that this patient is a COVID negative, we still consider the patient that my RT-PCR test would be wrong. And we keep taking all the precautions to be taken according to the false negative rate of the test. All investigations and clinical examinations completed, maintaining the social distancing norm. Soon to start, we have to going to start a double temperature check for all patients and healthcare workers. In the OT procedure, we now do only under PPE and N95 mask, a must for the assistants and the operating surgeons. In fact, we use a 3-ply mask in addition to an N95 mask. Patient has to mandatorily wear an N95 mask. Window ACs are turned on only in cases of fogging. Minimum OT personnel inside OCT, and if possible, case completed alone, lone warrior. LA is preferred over GA. However, in unavoidable circumstances, GA is given. And what we do is that the GA, the point issue is that when you are going to intubate the patient, the exposure to the anesthesia is at that point of time. But then it's a circuit and then it has an exhaust valve. So if the circuit is on, it keeps discharging the coronavirus into the whole OT. So you have to, so there's a filter there. So you have to put a double exhaust filter when you are using a GA patient, when you are using a GA machine. Now, this is a hypothesis. I think, personally feel, eventually we'll have to adapt ourselves with the omnipresence of coronavirus. Your AIS guidelines for tackling only emergencies can hold true for my 30 or 60-day lockdown at most. It will not hold its validity in a prolonged pandemic predicted to last for 6 to 12 months at the best case scenario. And mind you, this is the best case scenario. No foreseeable change in the pandemic states, apart from sliding further downhill regarding the viral load in general population. And this is what I'm talking about India. Tackling only emergencies in near future is an opportunity to understand your infrastructure, bring necessary changes, and gradually open up your OT for various procedures, ensuring a zero cross infectivity. And what is ensuring a zero cross infectivity? Now, this is a very pertinent question. What about a patient who is a COVID positive with an ocular emergency? What you are going to do about it? I think institutional and multidisciplinary health personnels will soon lose the leverage of denying treating an ophthalmic emergency who is a COVID positive. It will be expected from them to provide mandatory care even a patient is COVID positive, considering other disciplines will be already providing these cares like emergency ops. They won't refuse it, emergency cardio or trauma and emergency. So the aim will have to be to establish a foolproof system to treat a COVID positive and then ensuring zero cost infectivity of your healthcare worker. And this has to be done by early identification of at-risk patient, professional handling, creating a barriers through PPE and hospital infrastructure. How to identify a corona positive in all OT patients? There are a few subjective like history and trials, mandatory travel history, recent loss of sense of taste or smell, the Arogya Setu app, which we all are talking about, risk profiling, like whether the patient belongs from a hotspot zone, whether he has some professional hazard, but these are subjective. I think you all should go for an RT-PCR and COVID serology. Most of it is available now. And RT-PCR is the gold standard. Once RT-PCR is positive, that means the patient is positive. But if you do an RT-PCR and then you do a COVID serology, in COVID serology, if IgM is positive, repeat the RT-PCR every CV days till 2 consecutive negative RT-PCR is there. If IgG is positive, again repeat an RT-PCR after 7 days and then only term the patient as a convalescent who has recovered from the corona. What are the additional tests to cause false negative? I think X-ray chest, AP, and lateral is a must for every patient. C-reactive protein and procalcitonin levels. C-reactive protein is not raised that much in a patient of COVID, and procalcitonin levels are increased. Once you have done all these patients, you can have a set of patient who is a corona positive with who requires an elective surgery. Postpone the surgery for 60 days, repeat the same protocol, inform the COVID center. So this is easy, done. Then we'll have a very small patient who will be a corona positive with which requires an emergency surgery. This has to be dealt in an institutions with required infrastructure, and the government will have to ensure that there is an institution which is there. And this will be a very small subset of our OT procedure. Only few institutions will have required infrastructure to carry out these required interventions. And there will be a big subset who will be a corona negative, and they would be considering for elective or emergency surgery. What is important is that all preparation and protection, you must do it assuming it to be a false negative. So how do you restart your OT? Get a baseline evaluation of all your OT personnel and healthcare workers for COVID status through either serology or RT-PCR. Twice check every staff for temperature and any other positive symptoms daily. This is a mandatory. It should be like a logbook. You should maintain it. If working in a large setup, divide your personnel with alternate work and 14-day quarantine period. Solo practitioners with comorbidities or high-risk category can take help of young surgeons for performing surgeries or surgical outsourcing. This is one option I think about. Appoint senior personnel with appropriate PPAs at the most crucial checkpoints. So this is very important. How do you restart yourself? Start with either single emergency or single elective surgery. Get RT-PCR 1 day before. So how do you manage your test? Get your RT-PCR test done 1 day before your scheduled surgery. And the serological test, I think, and X-ray test should be done in the morning so that you have the maximum chances of getting positivity of the surgery. And patients should be put in a, once you have come and designated that this is a confirmed COVID negative patient according to the test, you move that patient to a pre-designated quarantine area. Don't allow the patient to move around here. And this area should be somewhere near the OT after all the negative results. Maintain appropriate barriers and distance while mobilizing patient from the quarantine area to the OT room and involve minimal personnel. I also think that ask your assistant to arrange your OT table, keeping consumables in extra, and sit outside in another sterilized room. Since you are doing only one surgery in a day, try to complete the surgery without the help of the assistant. Use disposable eye drapes. I think many of us don't use disposable eye drapes, but this is a better barrier than in addition to a cotton drape. This will prevent the patient's breath from coming up. Non-permeable disposable eye drapes should be preferred. Ensure complete sticking around the nasal area. Reinforce the cotton eye drape opening with stickers. And I think mandatory N95 mask for patients from pre-op to OT is a must. And what is important that when the patient is donning the N95 mask, there should be an observer who should be asked to examine for adequate fit and whether the patient has any discomfort. And dry run this patient with an N95 mask in the pre-op or the quarantine area. What about the PPE and the ophthalmic surgeon? I think face shield is not at all compatible with the surgeon's eye-ear-face interface because once you don the face shield, you'll not be able to perform the surgery. Protective goggles is also a complete no because this will interfere with your visualization. You should make either a zero power glasses or you stick to your own prescribed glasses and adhere protective shields on both the sides. I think within time, there will be high quality eye drapes which will be available, which can assume to be acting as a sort of barrier between the COVID patients and us. The comfort level of the surgeon decreases a lot after donning PPE. So you have to check dry run yourself. I just so you should so you should keep drying. Double gloves and double shoe cover if possible. You always use a double layer suit and full PPE protection for OT assistant and everyone. Sorry. How to go about ophthalmic surgeon and multiple surgeries. Surgeons should initially plan for a single surgery in a day if using single room setup. Re-sterilize all instruments, phaco tips, handle especially. Disinfect the whole OT along with instruments. UV light has been reported as a potent killer, and minimum 20 minutes gap between two surgeries. Viral load in a what about ophthalmic surgeon and the chances of generating aerosol? Viral load in a COVID patient in aqueous still not determined. We need to have some studies coming on up with, and phacoemulsification can be a potential aerosol generating procedures as has been reported. What about type of anesthesia? I think you should convince most of the patients to undergo the procedure under local anesthesia. In case you have to use a GA, place additional heat and moisture exchanger filter on the expiratory limb of the circuit. Both HNE filters and the soda lime should be changed after each case. Intubation techniques with the highest chance of first-time technical success should be preferred to avoid repeated airway instrumentation. Medical and nursing staff must be equipped with FFP3 filters during laryngoscopy and intubations. What should be the change in our operating theater? Negative pressure ORs would be the ideal to minimize infection risks. However, ORs are normally designed to have positive pressure air circulation. So how can you compensate it? You can compensate it by increasing the air exchange cycle rate, which ideally is mandated to have more than 25 cycles per hour. This is a very important tip, is how to, once you have, even the patient is COVID negative, there's a very high chances that it might be a false negative. So you should have to develop a protocol for best disposal management. And this is a few of the things. And if you are to be, how to develop a case of COVID positive, treat a case of COVID positive with an ophthalmic emergency. I think this is to be handled by an institution with multidisciplinary team and past experience in COVID management. Current ophthalmic infrastructure is insufficient and require a dedicated ophthalmic COVID OT setup with an anesthesia facility. And COVID positive with ophthalmic emergency would be a rare combination. However, due to the limited number of specialized centers in an area dealing it with, that center can get overwhelmed. This is one of the protocol and how to go about to treat COVID-19 patients in OT. And we have only one literature that I could access, that was on China. This was a letter to the editor on how to handle the emergency of ophthalmic surgery during the prevalence of COVID-19. They treated both COVID positive and COVID negative only emergency procedures. They didn't have any access. I don't have any access to the number of surgeries they performed. However, the important comment was their total number of infected healthcare workers within the 3-month time period was 0 by using all the precautions. So to conclude, you should take a personal call, assess yourself in view of your prevailing comorbidities and stratify your risk status. Despite all negative tests, there is a potential risk of false negative patients, and performing OTs can bridge all barriers created between the surgeon and the patient. Take a temporal call. Assess your area, city, status every 7 days. Your area or city can transit from a very fast from a green zone to a hotspot. Few waves are expected in different time of coming years. Adapt yourself and team accordingly. Develop a teamwork and rotate your team between working days and quarantine days. Thank you. This is nice.